So the Women's Health Innovation Center is about all types of innovation in women's healthcare, not only telemedicine. We deal with artificial intelligence and extended reality and precision medicine, and when needed, even simple mechanical devices, everything that does the work. So originally, I was invited to Stanford after inventing a mechanical device for preventing preterm birth, that in the meantime was commercialized as there's a company commercializing. It's called Pregnantech. The device is called the Lioness. Pregnantech. The device name is the Lioness. It's still in the development. It's not really clinically used. But that was my first.
What does it do?
It's a mechanical device placed around the cervix that prevents the early cervical remodeling, and by that way prevents mechanical etiologies of preterm birth. That was my first invention about 6 years ago. But because mechanical devices have a long path until they get FDA approval, this device is not being used currently. It's more in a process of development by a commercial company. Anyway, that was 6 years ago. In the Women's Health Innovation Center, we're developing, I'm starting from around, and then I'll focus on telemedicine, which we'll be discussing today.
Okay.
In the Women's Health Center, our current focus is in 4 things. First is artificial intelligence. We're developing artificial intelligence models that improve decision making during pregnancy and in the labor and delivery ward. So for an instance, I developed an AI calculator that predicts a very common complication during labor and delivery called shoulder dystocia. That's when the baby's head comes out, but his shoulders are stuck. So since it was first presented 100 years ago, it was considered an unpredictable complication of labor. But using artificial intelligence, we're able to predict it in Israeli data and then show that it works also in America. And we validated it in UCSF, University of San Francisco, in Stanford, and at University of Texas, Houston. So it works both in the Israeli population and in the American population.
And will you bring it to South America?
Hope someone will. So the shoulder dystocia calculator is out there for free. It can be used by any physician. Or such an important issue, we decided not to protect it by IP or patent it or anything. It's just there for free. So if there's a hospital in Mexico that's interested to check if it works in your population, we'd be more than happy to work with them. Similarly to our work with universities in the United States. And similarly to this calculator, we're developing other AI calculators predicting other complications during pregnancy, such as unplanned cesarean section. Maybe you don't need to put in too much details, but we're similar to the shoulder dystocia calculator, we're developing other calculators predicting other important complications during pregnancy and during labor. And another field of innovation we are working on is using extended reality in labor and delivery as a substitute. Currently, I don't know how it works in Mexico, but in Israel and the United States, most women in labor and delivery use an epidural, some kind of regional anesthesia.
Also here. Yes.
Yeah, that actually prevents them from moving around They have to stay lying down once they have the epidural. And we're trying to start using extended reality, actually augmented reality. That's when you put kind of, do you know what augmented reality is?
Yes, when you scan, you scan something and you can see something going on.
So yeah, quite close. So when it's kind of, you know what virtual reality is? Kind of when you put on kind of goggles and you see something else.
Yes.
Yeah. So we are trying to start using virtual reality.
And how?
So women come with contractions, but they're not at birth yet. So we give them goggles and allow them to walk around instead of lying down with an epidural when they're not at labor yet. We give them these goggles that allow them to view, you know, whatever they want. It can be whales in the sea, it can be lions, it can be elephants, whatever they want, and it kind of allows them some kind of distraction from the pain. So it's not good for all women, and it's not good for all stages of labor, but it is good for many women at early stages of labor. And what we want to show now is that by delaying the need for regional anesthesia, we hope to improve the labor outcome, because that they're allowed to move around instead of lying down. That's our assumption. We didn't prove it yet, but we assume they will have better outcomes during labor and delivery. So we discussed AI, we discussed extended reality, and of course, most important maybe is precision medicine. That's something that is used in many other fields of medicine, like oncology. So currently, oncologists don't just treat a woman with ovarian cancer or lung cancer with the same treatment for all women, for all patients. There's a specific treatment that is derived from the patient's molecular profiling, from the cancer's molecular profiling. And each patient and each cancer has its many subtypes of treatments. While in our field of maternal fetal medicine, all women are treated with the same treatment. So all women at risk for preeclampsia are treated with low-dose aspirin, and all women at risk for preterm birth are treated with progesterone. However, it helps only 10 to 20% of them. So there is a real need to find the right medication for the right women at the right time. And I think we will be able to be leaders in that field of finding the molecular phenotype of women at risk for common pregnancy complications and finding the precise treatment that will help a specific patient, not only the average patient. And after talking about all these, we reach telemedicine, which is something that is actually very new for all of us. I didn't deal with telemedicine until a year ago. I started thinking of telemedicine only following COVID-19. And the reason I didn't think of telemedicine so much was it's so complicated to use telemedicine during pregnancy. I mean, not like internal medicine, where, you know, all you need is to see the patient and measure his blood pressure and maybe his pulse rate or saturation. In our field, there's a baby. And when there's a baby, it's not enough to be able to see the patient. We need to see the baby. And you cannot see the baby without an ultrasound and fetal heart rate monitoring. And all these were not possible. And because of the COVID-19, we really looked into the newest technologies and discovered there are a few cutting-edge companies that have developed ultrasound devices for using at home and a fetal heart rate monitor for using at home. And now we are going to start working together with them. So some of our patients, like post-date women, low risk pregnancy women that reach post-date pregnancy, will be able to come to Sheba receive an ultrasound device, a monitor, and go home, and then keep the follow-up from home. Our doctors will ask them questions. Our doctors will follow their vital signs, that's the blood pressure. Our doctors will follow the urine by looking at the urine stick, and we'll also follow the baby. We'll be able to, the woman will hold the probe, the ultrasound probe, above her belly, and we are able to, we have a method for interpreting what we need. Actually, all we need from the ultrasound is, for this purpose, is the deepest amniotic fluid pocket. That's the amount of amniotic fluid in the belly, in the uterus, and the fetal heart rate, which will be using a special device that does that at home. So actually, post-date women that will be coming for follow-up at Sheba from, hopefully from November, will be allowed to continue their follow-up at home. And they'll only have to come one time.
The whole pregnancy?
No, so the whole pregnancy, women don't have every few days follow-up. They have follow-up, you know, in the beginning of pregnancy, then they have anatomy surveys, then they come back a few times. But when they reach 40 weeks, at least at Israel, they have to come for follow-up every 2-3 days. And we want to replace that follow-up with at-home follow-up.
But don't you think the relation between the patient and the doctor is also very important? Like to talk about if she's anxious,
Yeah.
or she's worried.
So yeah, that's a very good question. So first, if a woman wants to come, she's very welcome. And the other thing is that the patient will talk with the doctor, but she will do it. So currently women come, wait in line for an hour for the ultrasound, the technician ultrasound test. Then she waits another hour. That's the best case, right? She waits another hour for the fetal heart rate. And then she waits another 2 hours for the doctor. The doctor sees her for 5 minutes, asks her if she has any contractions. Does she feel the baby moving? She says, yeah, no contractions, the baby's moving nicely. And then he looks at the paper of the ultrasound, it looks okay. He looks at the heart rate, looks okay, and he says, okay, you can go home, come back in 2-3 days. So that's how it works in all places. And you know, she just wasted one of the last days before delivering, instead of spending time with the children, instead of finishing up work, instead of having a good time with her husband. She's stuck waiting 4 hours for something that could be done in 10 minutes at home. Then if she wants to ask the doctor questions, she can do it online. I mean, just as we are speaking now, it's a video. She sees the doctor sees her, they can talk. You're right, there is something in sitting together in the same room. So for some women, they may prefer to come, and that's fine. But I'm sure many women would prefer to stay at home. And the other thing is, after the women deliver, we are going to be able to follow them at home using, again, an internet application that will allow us to follow all aspects of postpartum pregnancy complications, from minor things like depression and problems with breastfeeding to the major severe urgent complications such as deep vein thrombosis, infection, bleeding, and things that require immediate response. So for all of them, we will be able to keep following women at home. So hopefully, once we start running the application, and all these things, the new things that will start only at November, and once we start doing these things, at least the women that are interested will not have to stay at hospital after delivering. And again, it's important to remind that we are preparing for a tough winter with a kind of combination of COVID-19 and influenza. And the more women, that's how we see it, at least. I don't know if it's agreeable all around the world. But our feeling is we want to give women best treatment at home. We want them to be safe at home, but in the same time receive all treatment as good as, and sometimes even better than if they were at hospital.
Yes, well, this is a revolution for medicine, because then women from underdeveloped countries could maybe get access to better diagnosis from.
Yeah, that's a really good point. That's true. So currently, at Sheba we think of ourselves as one of the best hospitals in the world, but currently we serve only Israeli population. Our hope is that once we have the ability to follow patients, so currently when we start, we're going to be treating at home women living very close to Sheba, at Ramat Gan and Tel Aviv and Bnei Brak, but then we can treat women everywhere in Israel, and actually we can treat women everywhere in the world. So it's going to be really interesting, and of course other hospitals may be interested in it. So I think the telemedicine, and in this case maternal fetal telemedicine, is really making the world flat.
And you can also share the knowledge about the patient with another doctor that could complete the diagnosis, maybe a doctor in another specialty.
Yes, well, I understand what you're saying. That's always true. That was true also without telemedicine, but it is true that if I understand correctly what you're asking, that as we move forward with telemedicine, we'll be able to see sometimes some patients need a kind of a multidisciplinary team, kind of a patient that needs both a nephrologist and an obstetrician. And yes, so once we had to sit together in the same room, the nephrologist and the obstetrician, and now we can be sitting one at every place, like a kind of a Zoom meeting. But the important thing is that we can do this for more than a year, talk with patients at Zoom, since Zoom exists. But what we can do now is examine the patient. We're able to examine the patient, and the real innovation is that we are able to examine the baby. That's the real innovation, that we're able to assess the well-being of the fetus, although the woman is far away from us.
Wow. And tell us a little bit about the C-section you did to a woman with coronavirus.
Also, actually, we had a few C-sections for COVID-19 women at Sheba. I had the privilege of, actually, myself, I had 4 cases of COVID-19 C-sections. 4, yes. What can I tell about it? I can say that all women are feeling good now. 2 of them were symptomatic and 2 were asymptomatic. The 2 that started, 2 of them. So at Sheba, we test all women for COVID-19 when they come to labor and delivery. So sometimes women come asymptomatic and we just discover it by chance. So 2 of the women I had, I treated with, had C-section. So, and another thing is COVID-19 is not an indication for C-section. So all women had C-section for other indications.
But it's not dangerous that the baby would get infected?
So none of the babies at Sheba were infected with COVID-19, and data gathered from around the world does not show, not during labor and delivery, because COVID-19 is a respiratory virus with some presence in the gastrointestinal tract. We've been testing, so far we did not observe COVID-19 in vaginal fluid or in babies delivered. And anyways, a C-section route should prevent also that option, because women delivered with C-section, the baby doesn't go through through the vaginal canal, and is just taken straight away from the amniotic membranes out to the world, so we shouldn't get infected. What can I say about the surgery? It's hot. You're in a room with a lot of covers, right? You have about 3 layers, and you can't have it's very hot in Israel. I don't know where it's hot, in Israel or in Mexico, but it's very hot in Israel right now.
It is hotter in Israel.
It is hotter. So it's very hot and humid in Israel. And you add on it, you can't use the air conditioning. So it was tough.
You can't use the air conditioning?
We can't use air conditioning in COVID-19 surgery because you don't want it to spread around the the air conditioning kind of spreads the virus in the air. So we're not allowed to.
I didn't think of the air conditioning.
Yes, neither did I. But the nurses remembered. The nurses remembered to put off the air conditioning.
And now you look awfully young. How is it?
Not so young. 40. I'm 40.
Ah, yes, you look younger. So
Oh, thank you.
You've already been to Stanford. You're already back, and now you are the director. I think Israel is really a land that can detect people even when they are young. No.
Yes. I don't know what to say. I was really lucky. My career path was very lucky, and the decision the hospital made to establish the Women's Health Innovation Center is really a great opportunity. I don't think there's such a thing anywhere in the world, a Women's Health Innovation Center that's focused on developing new solutions for old problems in women's healthcare. And I see that, so we've been discussing all our talk, the opportunities we are bringing to women in Israel that are treated in Sheba, but the other thing is we see there's a lot of enthusiasm from many companies that want to enter this field of femtech. They want to innovate in the field of women's health. They want to invent new things that will improve women's health, and they are looking for someone to collaborate with. And there's not a day that we don't receive emails from companies that want to work with us. So it's really a very exciting time. It seems like everything is open, and we can really think openly about what we want to do and what our clinical goals. And once we set them, we can find the right company or the right lab or the right university to collaborate and achieve these goals. It's really exciting.
It's interesting that you are willing to share your new inventions with whatever hospital you said, like in Mexico, that would want it for free. Why are you doing this?
So not all our inventions, but the shoulder dystocia calculator. So the shoulder dystocia is a problem that when I was a resident, I always feared it so much. And I never thought we could really succeed in predicting it. It was kind of a long shot, and we were so excited we succeeded, and that we can really make a change in every labor and delivery ward. And we decided, and also I feel I have the privilege of inventing many things. So I decided that this invention we will give as a present to the world. And actually the truth is also that, and that's something we see now, that when something is not protected by a patent and it's out there for free, it's much easier for it to move forward. And, instead of lawyers having long arguments of who this belongs to, and the hospital's lawyer and the university's lawyer and our lawyer, it's just out there for free and everybody can use it. And both me and specifically the shoulder dystocia calculator, I developed it with a data scientist, a very good data scientist from UCSF, which is also an Israeli, Dvir. He's now back to Israel. He's now head of the bioscience cathedra in the Technion. And we both felt the same about it, that we have many inventions and we want to give this one to the world.
And what else do you have in mind? What other inventions are you thinking about?
So, no, I don't think we can reveal our next inventions, but I promise the next year is going to be full with many inventions that will come from we have really very cool things. None of them are the same like the previous things. We're working about very cool things. And one of the things I'm really happy about is that since I started leading the Innovation Center, we have many residents involved. You know, there's nothing I enjoy more than the young residents coming to me with a kind of a starting of an idea, and we work on it together. And, you know, and we have I see in their eyes what I had when we just started, you know, this kind of passion to change the world. And I think the next year is going to be full of many inventions coming out of our innovation center. Some of them that we worked on ourselves, some of them are in collaboration with other places, which is also very fun, the working together. So I promise to talk about them once they're out there.
Because, you know, in gynecology, many of the devices that are used on women when they are there is an exploration, when they are looking, are devices that are really old.
That's right. That's really true what you say. That's really true. That not much. Well, I always used to say that if a gynecologist that passed away at 90, 60 would come back to life, he could return to work immediately. Nothing really changed. You know, if an internal medicine expert that passed away at 1960 comes back, everything changed. They take his license. But a gynecologist, he could just go back to work immediately. No, nothing changed. The same progesterone, the same everything. I hope we're going to have an opportunity to contribute to making a change, because no doubt there is a need for change at all aspects of women healthcare, from IVF through pregnancy, postpartum, menopause. Even, you know what? Even the speculum used for everything must change. Everything must change, and everything can change. And I think the world, you know, women are 50% of population, so there's a great drive to make this change, and I'm happy we'll have a nice part in this change.
Do you think it is because of misogyny that these have not changed? Because women are not like taken into account as they should?
I don't know. It could be part of it. I tell you, another important part is that pregnancy, because of pregnancy being so precious, and because of the history of various medications causing various birth defects, I think that industry is very concerned of trying new treatments for preventing pregnancy complications. So part of it is kind of more overprotection. We are so careful not to try anything new during pregnancy that we don't have what is needed to develop the medications needed to prevent the major pregnancy complications, and we're paying for it because, you know, preterm birth causes I mean, really early preterm birth, earlier than 32 weeks, it causes, it's dangerous for the baby. It's very dangerous for the baby. And it, you know, a baby that is healthy, has good genetics and has good anatomy, and is born too early, it changes life course. It changes his life course, and it changes the life course of his family. That instead of going to work, have to stay with him, and you know, even if everything is okay, and he just has to be in the neonatal ICU in the NICU for a few months, it costs a lot, both for the health insurance and for the society. And you have currently, you have 8% of deliveries are preterm birth, and these percentage did not change. You know, you look, even though there's so much money going into preventing preterm birth, there's no change in the last 20 years. The numbers are staying around the same in the United States. The same with preeclampsia, the numbers are actually rising. When I was a resident, we were taught it's around 4 to 6%. I just prepared a lecture for our residents, and I saw the current numbers are 5 to 8%. So until we have the courage to try new medications, and even more importantly, to find the right medication for the right patient, we will stay with the same percent of complications. So at least the pregnancy, I think.
You say it's more.
Yeah, so the change, the increase is not dramatic. The increase is very slight. It's from 4 to 6 to 5 to 8. But it's more, the most important thing is that what we're doing is not good enough to make the change needed.
So we will be waiting for your new inventions, and I'm sure you will revolution also the world of gynecology.
I hope.
Thank you so much for the interview. And,
thank you.
And we hope people in Mexico, and we will be interested, and we will contact you very, very soon to know about your techniques and your artificial intelligence discoveries.
Okay, looking forward to viewing it.